Hello everybody. Today we are going to discuss about the question which was asked in critical care exam. The question was enumerate various commonly encountered issues in the management of obstetric patient in ICU and describe their management. So we'll discuss about preeclampsia. Pregnancy is the physiological phenomenon with high potential for severe pathological state that can be life-threatening for both mother and fetus. So preeclampsia and the related disorder are the common cause of the fetal maternal morbidity and mortality. So preeclampsia and the related disorders complicate around 5% to 7% of pregnancies and contribute from 35 to 44%. 93% of obstetrical intensive care admission. Worldwide, the hypertensive disorder are most common cause of maternal mortality, accounting for nearly 14% of maternal death. In low to middle income countries, many of these deaths could be attributed to the lack of access to the basic antenatal care and the intensive care facility. About definition and diagnostic criteria. Gestational hypertension is defined as systolic blood pressure of more than or equal to 140 mmHg or diastolic blood pressure of more than or equal to 90 mmHg or both on two occasions at least 4 hours apart after 20 weeks of gestation in a women with the previously normal blood pressure in the absence of other features of preeclampsia. Now, the preeclampsia is defined as blood pressure, systolic blood pressure of 140 mmHg or more, and diastolic blood pressure of 90 mmHg or more, on two occasions at least 4 hours apart after 20 weeks of gestation in a woman with the previously normal blood pressure, or systolic blood pressure of 60 mmHg or more, or diastolic blood pressure of 110 mmHg or more, to facilitate timely antihypertensive therapy. And proteinuria, that is 300 mg or more per 24-hour urine correction, or protein creatinine ratio of 0.3 mg per dl or more, and dipstick reading of 2 plus. Or in the absence of proteinuria, new onset hypertension with new onset of any of the following. That is thrombocytopenia, platelet count of less than 1 lakh, renal insufficiency, serum creatinine ratio greater than 1.1 mg per dl, or doubling of the serum creatinine concentration in the absence of other renal disease. Then impaired liver function, elevated blood concentration of liver transaminase to twice normal concentration. Then pulmonary edema, new onset headache, unresponsive to medication, and not accounted by the alternative diagnosis. And then visual symptoms. So this is the flowchart of the hypertensive disorder in the pregnancy. So if there is hypertension and if the gestational age is less than 20 weeks, then it could be the chronic hypertension, and there are chances that preeclampsia may superimposed on the chronic hypertension. And if there is hypertension and the gestational age is more than 20 weeks, then we need to look for the proteinuria. If proteinuria is absent, then it is labeled as gestational hypertension. If proteinuria is present, then the preeclampsia. Then we need to look for the other severe features, like if systolic blood pressure is more than or equal to 160 mmHg is there or not, or diastolic blood pressure of more than 110. Then we need to look for the presence of acute kidney injury, elevated liver enzyme, thrombocytopenia. If along with elevated liver enzyme and thrombocytopenia, if hemolysis is there, then it is HELP syndrome. Then we need to see the features of pulmonary edema, new onset headache, visual disturbance, and seizure. That is, if it is seizure, if it is complicated by seizure, then that condition is labeled as eclampsia. Now, preeclampsia with severe feature. If systolic blood pressure is more than or equal to 160 mmHg and diastolic blood pressure is more than or equal to 110 mmHg on two occasions at least 4 hours apart, thrombocytopenia, impaired liver function that is not accounted for by alternative diagnosis and is indicated by abnormally elevated blood concentrations of liver enzyme or by severely persistent right upper quadrant or epigastric pain unresponsive to medications. Then renal insufficiency, serum creatinine concentration of more than 1.1 mg per day or doubling of serum creatinine concentration in the absence of other renal disease. Pulmonary edema, new onset headache unresponsive to a medication or not accounted by alternative diagnosis and visual disturbances. Now, what is eclampsia? Eclampsia is defined as new onset tonic-clonic, focal, and multifocal seizure in the absence of other causative conditions such as epilepsy, cerebral arterial ischemia, infarction, intracranial hemorrhage, or drug use. Now, what is HELP syndrome? HELP syndrome is defined as hemolysis, elevated liver enzyme, low platelet count, and it is one of the more severe form of preeclampsia with drop in hemoglobin with lactate dehydrogenase, that is LDH level elevated to 600 international unit per liter or more. Aspartate aminotransferase or alanine aminotransferase elevated more than twice the upper limit of normal and platelet count of less than 1 lakh. Then the risk factors for preeclampsia is nulliparity, multifetal gestation, preeclampsia in previous pregnancy, chronic hypertension, pregestational diabetes, and gestational diabetes. Thrombophilia, systemic lupus erythematosus, pre-pregnancy body mass index of greater than 30, antiphospholipid antibody syndrome, maternal age 35 years or older, kidney disease, assisted reproductive technology, and obstructive sleep apnea. However, it should be noted that most cases of preeclampsia occur in healthy nulliparous female with no this risk factor. Now, pathogenesis of preeclampsia. Pathogenesis of preeclampsia is best explained by two-stage paradigm considered to involve two stages, that is abnormal placentation and the development of maternal syndrome. Abnormal placentation. Placental ischemia and hypoxia play an important role in the pathogenesis of preeclampsia. Acute fibrinoid necrosis of vessel wall and the defective myometrial spiral artery remodeling are prevalent in the histopathologic studies of preeclamptic placenta. Abnormalities in the cytotrophoblast differentiation with defective placentation and failure to transform uterine spiral arteries are central to the pathogenesis of preeclampsia. Persistently elevated expression of hypoxia-inducible factor 1 alpha in preeclamptic placenta could indicate its pathogenic role in the preeclampsia. Imbalance between pro-oxidative and antioxidative mechanism mediated by the heme oxygenase pathway also lead to abnormal placentation. Immune mechanism implicated in the defective placentation include abnormalities in the activation of decidual natural killer cell, allorecognition of the paternal major histocompatibility complex, predominance of T helper 1 cell, related cytokines, and abnormal activation of complement system. Then maternal syndrome. The abnormal placenta secretes excessive anti-angiogenic factor that causes the maternal vascular inflammation and endothelial dysfunction. Imbalance between pro-angiogenic and anti-angiogenic factor as evident from the increased soluble films like tyrosine kinase 1 and soluble endoglin along with decreased activity of the placental growth factor lead to the vascular injury, inflammation and thrombosis and manifest as hypertension and organ dysfunction. Hypertension could be mediated through agonist autoantibodies that bind to angiotensin 2 type 1 receptor. Other possible mechanisms include causing hypertension include decreased level of nitric oxide, increased activity of endothelin 1, decreased placental expression of the cystathionine gamma lyase with reduced hydrogen sulfide level. The intense vasoconstriction along with the capillary leak makes these patients more prone for pulmonary edema. The exact pathogenesis behind proteinuria and preeclampsia are not clear. However, findings of glomeruloendotheliosis and loss of endothelial glycocalyx have been implicated. Thrombocytopenia may result from the increased platelet activation and consumption. Hemolysis is indicated by elevated LDH level, which may be seen in patients with HELP syndrome. Hematocrit may be normal despite hemolysis due to hemoconcentration. Elevated liver enzyme in the severe preeclampsia are secondary to the periportal necrosis. Placental ischemia can lead to fetal growth retardation, oligohydramnios, placental abruption, and increased risk of spontaneous preterm delivery. Convulsion develop as a consequence of cerebral vasospasm, hypertensive encephalopathy, breakdown of cerebral autoregulation, vasogenic and cytotoxic edema, cerebral microhemorrhages, and metabolic encephalopathy. About clinical feature, most of the patients with the preeclampsia are asymptomatic initially and diagnosed during routine antenatal visit. Onset is generally insidious with the symptoms like edema, which are often passed off as a normal effect of pregnancy. Hypertension, edema, and proteinuria are defining features of preeclampsia. Preeclampsia should be differentiated from the gestational hypertension of chronic hypertension. Proteinuria and edema are absent in the gestational hypertension and chronic hypertension. The other clinical features indicative of organ system involvement are seen in severe preeclampsia. New onset headache may be the sign of cerebral edema and posterior reversible encephalopathy syndrome. Visual symptoms include blurred vision, photopsia, scotoma, and blindness. Stroke due to intracranial hemorrhage is serious complication and always associated with severe uncontrolled hypertension. Hyperreflexia, ankle clonus could be the sign of neurological involvement, and seizure are the defining features of eclampsia. Pulmonary edema causing breathing difficulty occurs due to severe hypertension, left ventricular failure, and rarely capillary leak. Epigastric, upper abdominal, and retrosternal pain radiating to right hypochondria is also a feature of severe preeclampsia and occurs due to hepatic swelling or hemorrhage. Oliguria is common in severe preeclampsia due to intravascular volume contraction due to severe vasoconstriction, hypoproteinemia, and anasarca. Patient may present with features of antepartum and postpartum hemorrhage due to thrombocytopenia, DIC, and abruptio placenta. Then lab features include proteinuria, rate serum creatinine, thrombocytopenia, microangiopathic hemolysis like elevated LDH, indirect bilirubin, schistocytes, elevated hepatic transaminases, and elevated uric acid. Deranged prothrombin time may be seen due to liver dysfunction and is more common in acute fatty liver of pregnancy. Prolonged prothrombin time, partial thromboplastin time, fibrin degradation product, and reduced fibrinogen level are characteristic of the disseminated intravascular coagulation. Neuroimaging is done in patients with seizure, visual symptom, and altered consciousness to look for PRACE, intracranial hemorrhage, and cerebral venous sinus thrombosis. Now about differential diagnosis, various other conditions may mimic features of preeclampsia with severe features. HELP syndrome is closely mimicked by hematological abnormalities like thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Neuro- Neurologic features and renal involvement are more common in HOS and TT. Acute fatty liver of pregnancy can mimic HELP syndrome but has more severe hepatic dysfunction, prolonged prothrombin time, and higher incidence of acute kidney injury. SLE may present with hypertension, proteinuria, nephritis, thrombocytopenia, and seizures. Now, mimics of preeclampsia. Pre-existing renal disease, hypertension, and proteinuria before 20 weeks of gestation favor the diagnosis of pre-existing renal disease. Renal artery stenosis, early onset hypertension without proteinuria, and neurofibromatosis favor these diagnoses. Now, the another differential is pheochromocytoma. Diaphoresis, palpitation, blood pressure fluctuation, headache, chest pain, postural hypotension favor the pheochromocytoma. Cushing syndrome and primary hyperaldosteronism. Hypokalemia, early onset hypertension, proximal myopathy, thin skin, and osteoporosis favor this diagnosis. Then mimics of HELP syndrome. Thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Severe hemolysis, marked thrombocytopenia, milder elevation of liver enzymes, high LDH favor the diagnosis of HOS and TTP. Adams 13 activity is reduced in TTP. Acute fatty liver pregnancy, coagulopathy, the milder thrombocytopenia, hypoglycemia, and renal dysfunction favors this diagnosis. Then systemic lupus erythematosus, external manifestation disease, active during sediment, decreased complement activity, and elevated dsDNA favor diagnosis of SLE over HELP syndrome. Antiphospholipid antibody syndrome. Widespread thrombosis with rapidly progressive multi-organ failure is a feature of APLE. Viral hepatitis, fever, marked elevated liver enzyme, LDH, minimally elevated bilirubin, coagulopathy. In the absence of proteinuria and hypertension, favor diagnosis of viral hepatitis. Generally, any seizure presenting after 20th week of gestation is to be managed as eclampsia unless proven otherwise. Certain conditions with overlapping features include epilepsy, subarachnoid hemorrhage, hypertensive intracerebral bleed, cerebral venous thrombosis, and cerebral predictive and the diagnostic strategy for the preeclampsia. None of the predictive modality like clinical factors, biomarkers, and imaging tools by themselves has modest predictive ability. They have been utilized as a part of predictive algorithm with the fair success. One such a tool is uterine artery Doppler flow velocity measured at around 13 weeks of gestation. The level of biomarkers like PIGF, FLT1, ENG, FLT1 by PIGF ratio. PIGF and the ENG ratio have good predictive performance in the early onset diagnosis. Severe disease with the high negative predictive values. These angiogenic biomarkers can also be utilized to differentiate preeclampsia from diseases with the overlapping features. Now about preventive intervention. The role of aspirin in the prevention of preeclampsia is more studied, and various international guidelines recommended the use of low-dose aspirin, that is 75 to 150 mg, in pregnant female at risk of developing preeclampsia. Analysis of multiple trials has shown that low-dose aspirin, that is 75 to 150 mg, initiated before 16 weeks of gestation, is effective in reducing preeclampsia. Now, aspirin for the prevention of the preeclampsia. So, risk factor, that is history of preeclampsia, chronic renal failure, type 1, type 2 diabetes, chronic hypertension, autoimmune disease, and multifetal gestation, it is recommended to give the low dose aspirin if more than one of the high risk factor is present. In case of moderate risk like nulliparity, obesity, that is BMI more than 30, family history of preeclampsia, age more than or equal to 35 years, personal history of more than 10 years of pregnancy interval, previous adverse pregnancy outcome, and low socioeconomic status, then start with low dose aspirin. If more than or equal to 2, moderate risk factors are present. Oral calcium supplementation, that is 1 gram per day, may help to prevent preeclampsia, especially among female with low dietary calcium intake. Various other agents with the mixed results or under evaluation for prevention of preeclampsia include metformin, low molecular weight heparin, arginine, pravastatin, and vitamin supplementation. Now about management. The systemic approach is essential for the management of critically ill obstetric patients with preeclampsia and related disorders. A multidisciplinary team approach, including various specialties like obstetrics, intensive care medicine, anesthesiologist, neonatologist, are required to formulate a treatment plan. So this is the 5-step approach. Stage 1 is to differentiate between obstetrical and medical disorder with overlapping feature and initiate any specific therapy for the same. Step 2 is to identify various organ dysfunction and support failing organ system. Step 3 is to assess maternal and fetal risk from continuing pregnancy and to decide whether delivery and termination of pregnancy will improve outcome. Step 4 is to choose the time and mode of delivery, if necessary, like vaginal and then operate. Step 5 is to optimize organ function to ensure safe delivery. Then early and appropriate diagnosis is of utmost importance. Critically ill obstetric patient may have overlapping clinical features. Certain specific features may help clinch a diagnosis and initiate specific treatment if available. This has been discussed in brief in the section on the differential diagnosis. Patients with the preeclampsia commonly present with the accelerated hypertension twice. These patients have contracted intravascular volume due to due to capillary leak, which makes the blood pressure control without compromising organ perfusion and fetoplacental perfusion a challenging task. Overzealous blood pressure control is to be avoided as it can compromise blood pressure, worsen renal function, and decrease fetoplacental perfusion. Vasodilator antihypertensive are the logical choice in this condition. However, contracted volume with vasodilation may decrease the cardiac output by decreasing venous return and preload. This can be prevented by appropriate plasma volume expansion. However, overzealous volume expansion may prevent pulmonary edema, may precipitate pulmonary edema. Hemodynamic monitoring may help fine-tune and individualize the fluid vasodilator balance in patients with severe preeclampsia. The objectives of antihypertensive therapy include prevention of organ dysfunction like pulmonary edema, myocardial ischemia, renal injury, seizure, stroke, and placental abruption. Gradual reduction in the blood pressure to 140 to 160 mmHg systolic and 90 to 100 mmHg diastolic is optimal. Abrupt drop in the blood pressure may compromise uteroplacental perfusion. Antihypertensive agents used in the treatment of severe hypertension include intravenous labetalol, IV hydralazine, oral nifedipine, and IV nicardipine. Intravenous labetalol is the first line drug, and oral nifedipine may be used in resource limiting setting. Once the severe hypertension is controlled, the patient should be started on oral antihypertensive agent if expected management is planned. Oral labetalol 100 to 600 mg per dose, 3 to 4 times a day. Maximum is 2400 mg per day, followed by modified release oral nifedipine 30 to 60 mg per dose, 1 to 2 times a day. Maximum 120 mg per day. Or oral methyl dopa, that is 250 to 100 mg per dose, 3 to 4 times a day. Maximum is 300 mg per day are used. So this is the various antihypertensive medicines that we are using for severe hypertension. So one is labetalol, that is 10 to 20 mg IV, followed by 20 to 80 mg every 10 to 30 minutes. Maximum dose is 300 mg. Continuous infusion at a dose of 1 to 2 mg per minute. It is the first line drug. Onset of action is 1 to 2 minutes. It should be avoided in the situations like bronchial asthma, decompensated heart failure, heart block, and bradycardia. The next agent is hydralazine, that is 5 mg IV, followed by 5 to 10 mg every 20 to 40 minutes. Maximum dose is 20 mg. Continuous infusion of 0.5 to 10 mg per. Then onset of action is 10 to 20 minutes and it can cause maternal hypotension and headache. Then nifedipine, that is 10 to 20 mg per oral, repeated in 30 minutes if required. Then 10 to 20 mg every 3 to 6 hours. Maximum daily dose is 120 mg. Onset is 5 to 10 minutes. Then the adverse effect is reflex tachycardia, headache, and it is used commonly in resource limited setting. Then the next drug is nicardipine, that is continuous infusion. We can start it in the continuous infusion of 3 mg per hour, increased by 0.5 mg per hour every 20 minutes to maximum of 50 mg per hour. Onset is 10 to 20 minutes and the side effects are tachycardia and headache. Magnesium sulfate is recommended for the treatment and prophylaxis of eclampsia. MACPI trial shows that 58% reduction in the incidence of seizure in preeclampsia patient with severe features and with the use of magnesium sulfate prophylaxis. Magnesium sulfate is the drug of choice for the treatment of seizure in the eclampsia. And the doses, the intravenous magnesium sulfate regimen include loading dose of 4 to 6 gram over 15 minutes, followed by infusion of 1 to 2 gram every per hour. Magnesium level should be monitored every 4 to 6 hours, especially in patients with renal dysfunction, and doses titrated accordingly. Patients should be monitored clinically for the decrease in urine output, loss of plantar reflexes, and respiratory depression and cardiac effect. Decreased urine output may warrant more frequent monitoring and adverse effect needs stopping of magnesium infusion and may need administration of calcium glucose. Intramuscular magnesium sulfate may be considered in resource limited setting. And we can administer in the loading dose of 5 gram intramuscularly in each buttock, followed by 5 gram in alternate buttock every 4 hours. Magnesium sulfate should be continued for 24 hours after delivery or last season. Brain imaging, preferably MRI, should be performed in patient with the eclampsia to rule out intracranial hemorrhage, posterior reversible encephalopathy syndrome, and cerebral venous sinus thrombosis. Now, the clinical effect of the serum magnesium. Therapeutic effect is between the serum magnesium level of 2 to 3.5. If the serum magnesium level is more than 3.5, then there will be the loss of plantar reflex. If the serum magnesium level is more than 5, then there is a respiratory paralysis. If serum magnesium level is more than 12.5, then it has cardiac effect. Now, should we go for now delivery? Which delivery versus expected management for patient with the preeclampsia requiring intensive care? Prompt delivery, usually by cesarean section, rapidly reverses all life-threatening manifestation of organ failure. Expected management may be appropriate for gestational hypertension or preeclampsia without severe features in preterm period and would favor better fetal outcome. The risk of late preterm expected management include severe preeclampsia, eclampsia, HELP syndrome, and placental abruption are to be weighted against the risk of preterm delivery like neonatal complication of prematurity, including neonatal respiratory complication and need for prolonged neonatal intensive care. Nevertheless, in all critically ill obstetric patients, saving the pregnant mother's life takes the precedence over improving fetal outcome in terms of morbidity and mortality. In Habitat trial showed that induction of labor after completing 36 weeks of gestation significantly reduced new onset severe preeclampsia, HELP syndrome, pulmonary edema, placental abruption as a composite outcome without increasing neonatal complication when compared to expected management beyond 36 weeks of gestation. Habitat 2 trial showed that similar approach between 34 to 37 weeks of gestation worsened the neonatal respiratory complication. Before 34 weeks of gestation, expected management is intended to provide neonatal benefit at the expense of maternal risk. This approach needs the intense in hospital monitoring and delivery is recommended with any deterioration in maternal and fetal parameters. If time permits, 2 doses of intravenous corticosteroid should be administered 48 to 72 hours before delivery for the fetal lung maturity. During expected management at any time of pregnancy, immediate delivery is needed whenever there is deterioration in the maternal and fetal condition. Predicting system like SFLT 1 and PIGF ratio and full pyrus may help in identifying patient at risk of adverse outcome early by up to 48 hours, which is clinically useful period that allows steroid administration and planning for delivery. Various organ system dysfunction should be managed supportively. Pulmonary edema should be managed with oxygen supplementation and ventilation. Airway management in the preeclampsia patient is difficult due to both anatomical and physiological challenges. Coagulation disturbances due to diffuse intravascular coagulation and thrombocytopenia should also be treated with appropriate blood product. AKI should be managed with judicious fluid therapy and hemodynamic monitoring. Certain complication of preeclampsia and preeclampsia itself may present in postpartum period. The incidence of postpartum eclampsia ranges from 17% to 37%. Around 30% of HELP syndrome and cases occur in postpartum period. Appearance of this serious complication in the postpartum period warrants monitoring of preeclampsia patient in postpartum period for features of severe preeclampsia. Novel therapeutic strategy for pre-eclampsia are under investigation, include injection of recombinant VGF-121, PIGF, inhibition of SFLT1, small molecules, and small interfering RNA, selective depletion of SFLT1 with antibodies and apheresis, and none of this is recommended in clinical practice yet. Thank you, guys.